Today, we're getting under the hood of Tamara Taitt, a daughter, sister, and licensed as a midwife and a marriage and family therapist, and currently the executive director at the Atlanta Birthing Center. Tamara has a varied background in women's reproductive health activism and has been working in maternal, infant, and child health for the last 20 years. Tamara has a deep interest in the sustainability of the midwifery profession and politics as they relate to birth. On perhaps a permanent break from pursuing a PhD in family therapy, her clinical and research interests focus on exploring mental health issues that are pervasive during the childbearing years, particularly the experience of postpartum depression, post-traumatic stress related to birth, and perinatal bereavement. Tamara currently serves on the board of the Florida School of Traditional Midwifery. She is the owner of a private practice, Kindred Therapy for Wellness. And Tamara previously served as the Director of Student Life, Equity, and Access at the Midwives College of Utah and as administrator of the birth center she founded, Magnolia Birth House. Tamara shares a home with her partner, Michelle, her stepdaughter, 9 dogs, 2 cats, approximately 200 houseplants, and a 400-volume cookbook collection. Wow. I'd like to come over for dinner. Welcome, Tamara.
Thanks so much for this introduction. Great to meet you. I am currently in Atlanta, Georgia, where I've been serving as the executive director of the Atlanta Birth Center for the last several months. And I'm happy to have this conversation today and talk more about my work and our work and celebrate all of those and Pride Month.
Thank you. That's amazing. And I'm so excited to be getting under the hood of you. And I think the first question that I've been asking every woman has really been about, like, was there an inflection point in your life that got you into health and women's health, maternal health, or was there some sort of inspiration?
I was a women's studies minor in I actually don't know if I went to Princeton for undergrad, and I don't actually know if now you can be a women's studies major or African American studies major. But I was at the time there were certificate programs, and so I have a certificate in women's studies and African American studies from Princeton. And it was in my women's studies class. I was taking a class on gender and science. And we talked about midwifery and midwives in that class. I was a psych major, that was my major, and I also didn't have like a very clear sense of like how you actually became a therapist. And so some of the things that we would talk about in class, we are applying an academic lens. And there was another student in my class who was actually about to graduate, and she was planning to go to a nurse midwifery program. That was already her plan. She'd already applied and she'd already been accepted. And so that conversation about midwifery, doing some research at the time about like a very famous French midwife who had developed manuals for midwives. And it occurred to me like, oh, this is a thing that you can do. And up until that point, I had been looking at master's programs in women's studies as my next thing to do after graduating from undergrad. And suddenly I was aware of this whole like landscape of midwifery and what midwifery was, and then also the history of midwifery, specifically in the United States, how midwives are the first care providers for folks who are pregnant all over the world, except here. Midwives are the primary providers, the dominant providers for pregnancy. And so that just sent me down a rabbit hole of research. I read lots of books and first-person biographies of midwives. And then I ultimately decided that I was going to relocate to Miami, Florida, and do a direct entry midwifery program. So not to become a nurse midwife, but to become a direct entry midwife. And I think at the time I felt like I wanted to learn midwifery that was focused on community birth. And that even if I went on to do a nurse midwifery program, that I wanted my midwifery training to be grounded in community birth. And so that's how I ended up in Miami, and that's how I landed on like women's health and midwifery. It was really like history and gender studies and women's studies that got me there.
Thank you for sharing that, Tamara. I'm kind of curious about the community focus. What's the difference between community versus the nurse focus? And why did you go that route?
if you dial back prior to 100 years ago, the way that people became midwives was through apprenticeship, right? So your community has a need. There's a person in the community who serves that need. That person passes down their knowledge, So many, in much the same way that other skilled trades were learned, right? The person who cares for animals is a skill that they learn, even the way that, electricians learn now, plumbers learn now, doctors learn now. There is this component of learning from someone who's more experienced than you. And so the trade or the skill, the vocation of midwifery, that's how it was taught. And that sort of informal training process was probably part of the pathway of people becoming midwives, more so than how people evolved to be doctors, right? Midwifery probably actually had a more robust training pathway than medicine did when it first appeared on the scene. And so, doctors sort of veered into this domain of caring for women during childbirth, right around when our whole lifestyles started to become more industrialized. And so, birth in the community, like having your baby at home or having your baby in a maternity home or like a facility that's specifically for birthing, is really the way that people birth in the majority of the world and birth in the United States up until, let's say the 1940s and 50s. Many American presidents, for example, were born at home into the hands of grand elder Black midwives, in fact. And so there's industrialized and like technocratic approach to birth that's not very personal, that is part and parcel of the hospital, right? Any procedure you're receiving in a hospital system is very depersonalized, right? It's like being a cog in a machine, and having a baby is not a cog in a machine type thing, right? For you, at least, as the person who's giving birth, it's a very personal thing. It might be one of the biggest, if not the biggest day of your life. And so, doing it in community, meaning not being in a facility that is designed to care for people for all kinds of ailments, but being in a place that's really designed to care for someone who's birthing, creates a greater opportunity to have the individualized and personalized approach and attention. And so while I understood that the accessibility of home birth was limited in the United States, and the dexterity of direct entry midwives was also compromised. Direct entry midwives are not licensed in all 50 states the way nurse midwives are, for example. So I recognized even in that moment that I might opt to go to nurse midwifery school after training as a direct entry midwife. But I wanted my foundational learning in midwifery to be aligned with the way that midwives learned for hundreds and thousands of years. I didn't want to learn how to be a midwife in a hospital setting. And so I chose a hospital, an out of hospital pathway for becoming a midwife, because I wanted my midwifery education to be really aligned to the traditional way that people become midwives. And so even if I was taking classes, at a college, I was still learning midwifery hands-on the same way that someone would 100 years ago or 200 years ago, the same way that midwives would have learned, who delivered my grandmother or my great grandmother, that kind of thing. And so that was really the underpinning. In the United States, everywhere else in the world, 70–80% of babies are delivered by midwives, and midwives are the primary care provider for pregnancy and birth. In the United States, 8–11% of babies are delivered by midwives. Most of those babies are born in the hospital. 98% of nurse midwives attend hospital births. So most nurse midwives attend births in hospitals. And conversely, 99.9% of direct entry midwives, or midwives who are not nurses, attend births in birth centers or home birth. And home birth is happening all over the country. Some of it is attended by midwives, some of it is not attended. Families have the autonomy to make whatever decision they want. Birth centers are all over the country. There are over 400 birth centers. Some states have more than others. Georgia, for example, only has 3 birth centers that are currently licensed. But the state that the birth center that I founded is in, Florida, has had more than 30 birth centers for at least the last 10 years. Texas has over 90, California has 60. So there are people who are birthing in the community, either at home or with birth centers. And most of those people are having experiences that are in alignment with the experiences that everyone who was birthing was having 100 years ago in terms of that personalized approach.
That's a really beautiful way of putting it. Thinking about midwifery and the birthing experience from a historical perspective is fascinating. And your path is so interesting. It's kind of like your living history, if you will. So, how do you feel about taking the community midwifery route versus the hospital one?
I mean, I think that to support families in birthing in the community is like a reclaiming, right? Reclaiming something that belonged to us previously. And for families of color, for Black families, and for Indigenous and Native American families, the consequences of that departure from birthing in the community, while I think they were intended to deliver better outcomes, are at present day not doing that, right? So we know that Black women, Black birthing people, Native and Indigenous women are having outcomes that are significantly worse than their peers, their white peers, and those outcomes persist regardless of other things that we consider to be protective factors. So when you're looking at someone's healthcare, you consider them having a high income a protective factor. You consider them being well educated a protective factor. You might consider them living in an urban area potentially a protective factor. And when you look at Black women and Indigenous women, those protective factors do not protect them from having outcomes that are worse than white women who have none of those protective factors, right? So a married, insured by private insurance, PhD, MD, who attends all her prenatal care visits is more likely to have a negative birth outcome or a poor birth outcome than a white woman who's unemployed and underinsured who has not gotten any prenatal care. So something about the way that our system functions is not working for a portion of our population. And the stress, the embodied stress that racism causes in the lives of Black women and of Native women is resulting in outcomes that need improvement, that need to be mitigated. And so we know that when people receive care from culturally matched care providers, that their experiences of healthcare improve. And we know that midwives have better outcomes, traditionally than hospitals for normal low risk women. So if you're expected, 80%, 85% of women are expected to have a normal low risk pregnancy, then you're going to have an experience that is significantly different by going to a midwife. To use an example, like if let's say the C-section rate in like metropolitan Atlanta is 40%, right? The national C-section rate is 30%, 33% on any given week or year in the last several years. The birth center that I'm the executive director of, our C-section rate is 14%, right? And so why is that, right? We're also managing
14%?
Yeah, less than 14. Yeah,
Wow.
less than
Okay.
14%. Yeah.
Okay.
So there's something about the more whole person approach to healthcare that midwives provide that results in better outcomes, even among normal low risk women, right? So women who are not expected to have poor outcomes, their outcomes are improved. And some of that has to do with like their experience is different. Yes. So like how they internalize their healthcare is different, but like factually, their outcomes are also different. When you're seeing a person and you're only focused on their medical care, there's so many other things that are happening in their lives that can impact them. And so I think when I say whole person healthcare, I mean, it's not just whether I gained 2 pounds or I didn't gain 2 pounds, whether I'm, showing, that I haven't eaten today because there are ketones in my urine that you checked, or whether my belly is measuring appropriately. That's all part of what we need to consider. But am I, managing a kid who's just been diagnosed as autistic and having to go to IEP meetings? Am I caring for my elderly parent? And so I'm working all day and then working another 5 or 6 hours to help my mom care for my ailing father? Am I working at a checkout counter? And so I'm standing for 8 hours and that's contributing to my feet being swollen? swollen? Am I in an intimate partner violence relationship where I'm not able to advocate for myself, or I'm having conflicts in my home? And so you can't find out all of that other stuff that makes up the map, the landscape of my life in a 5-minute prenatal visit. And so, when, midwives spend more time with clients, they're doing all of those medical things, but they're also invested and interested in everything that makes up the fabric of your life, because all of those things, all of those threads are really impactful in how you experience your pregnancy. And our curiosity about those threads, our willingness to dialogue with clients about how they are managing all of those threads of their lives, and to problem solve with them, I think is part of what delivers the different outcomes. And having care that is individualized and personalized does as well, right? Because we're not all the same size, literally. We don't all have the same life experience. We're not going through all the same things. And so we really need healthcare that maybe is structurally constructed at a basic level that is good for us and is going to deliver what it thinks that we need, but then breaks down on a more macro level to give us specifically what we need and have the capacity to do that. And right now our system is not designed at a macro level to give us what we need, and it's definitely not providing what we need at that micro, person to person level.
There's so much to unpack there. I'm not sure where to begin. I mean, the system is the system, as you said, the macro, the micro, and it's not set up to have these nuanced conversations that actually get to know the person. And so the way you describe the whole person is very interesting to me, the fabric of human beings and the various labels that we attach to help us better understand people and actually what their lived experiences are. As the director of the Atlanta Birthing Center, and, you founded the Magnolia Birthing Center in Miami. Can you talk about your midwifery experience in each birthing center and I guess each state?
Sure. So, I mean, midwives in direct entry midwives are licensed in Florida and have been for almost 50 years continuously. So most southern states, I guess let me back up a little bit. Midwives as care providers in the American South, midwives were the primary caregivers for all families, not just Black families, but all families. So if you went back 100 years again, there were thousands of midwives in every southern state, thousands of midwives in Georgia, thousands of midwives in Florida. In the 1930s and 40s, there was a systemic approach that was led by physicians and public health to try to bring those midwives into the fold, so to speak, and to standardize the information that they had through licensing and training. But that same bringing them into the fold and training and licensing them was then used as a mechanism to exterminate them, right? To make those licenses invalid, to tell them it was time for them to stop practicing. And so that giant, robust workforce that existed, post-slavery through the 1930s and 40s, over time, those licenses were retired, and those licensure laws were no longer used or no longer considered to be active. And so that happened in Florida, it happened in Georgia. In Georgia, that's never been corrected, right? So the laws that were on the books in the 1930s have not been revived or reused. And in Florida, in the 1980s, groups of women who were attending births and who wanted to be able to attend home births and wanted to practice as direct entry midwives, most of them white, but some of them also people of color, got together and made a push with the state to get licenses issued. And so, Florida's midwives, Florida has, I guess, one of the oldest of the modern midwifery, direct entry midwifery legislation that exists in the United States. And so I'm licensed as a midwife in Florida. The birth center that I founded is in Florida, and Florida has, like I said, over 30 birth centers at a time when only 2% or 1% of birth centers were owned by people of color. So at some point prior to the pandemic, there were maybe, I think, 10 to 12, maybe as high as 15 birth centers that were run and owned by Black folks. 3 of those were in Florida, right? Ours, Magnolia, the Milton Memorial Birth Center, which goes back as a birth center all the way to the late 60s, and Common Sense, the Birthplace, which is Jenny Joseph's birth center in Orlando. And so in Florida, if I'm seeing, I can see clients legally, I can practice midwifery, I can provide full scope midwifery care according to the licensure laws in Florida. In Georgia, if I choose to do that, I'm actually breaking the law, right? So, there are direct entry midwives who live and practice in Georgia, including in the metro Atlanta area, but they are doing so in a state that is explicitly illegal. And there's some states that are illegal, which means it's not addressed one way or another. But there are states where it's explicitly illegal, and Georgia is one of those states. And so there are 38 states where direct entry midwives are licensed. Florida is one of those states, but Georgia is an illegal state. And so in Georgia, birth centers have to be owned and operated by certified nurse midwives. And so the Atlanta Birth Center is staffed by certified nurse midwives and nurses. We'd love to be able to hire certified professional midwives or direct entry midwives with other certifications. We can't do that because of the law. And so it will take like a legislative push to change the law. And there's been conversations and discussions about that in the state over the years, but nothing that made it to the legislature, that the legislature had the interest or capacity drive to pass. But it is certainly past time. And over the course of the 15 plus years that I've been in midwifery, all of the neighboring states have gotten themselves together. So there's a licensure law in South Carolina, there's one in Tennessee, there's one in Alabama as of a few years ago. There are some states that, Kentucky, if we're like expanding what we think of as the South, Mississippi is a state that doesn't have licensure, Georgia's a state that doesn't have licensure, North Carolina is a state that doesn't have licensure. And so part of addressing that licensure issue is that birthright legacy issue, right? Like there were thousands of midwives in all of these states providing healthcare to families. The United States' outcomes for birth, where more women are dying, more babies are born too small and too soon, that's not going to be fixed if there's a workforce issue. There are not enough OBs and certified nurse midwives to care for all these families. And so, states that are interested in improving their outcomes and in growing the options for care providers for families to address those outcomes need to look at licensure more closely. And so I'm certain that's certainly something that I hope shifts in the southern states where it hasn't occurred. But yes, absolutely, especially Georgia. In Florida, there are no restrictions on midwives owning birth centers. Direct entry midwives or licensed midwives, as they're called in Florida, practice autonomously. They don't practice under physician supervision. And so, they're able to sort of map their own, there's a law and a rule that they follow, and they, sort of map how they do that themselves. They make decisions about what kinds of clients they see. Some midwives exclusively do home birth. Some midwives do birth center birth only. Other midwives do prenatal care only, where they provide care for families who are not planning to give birth with them, but are going to have hospital deliveries, but want midwifery care. And even just providing midwifery care for pregnancy and postpartum improves outcomes. So it's not even about the midwife delivering the baby. Jenny Joseph, who's an experienced midwife who originally trained in the UK, has a birth center in Winter Park in the Orlando area. And she's created a whole healthcare methodology and model called the JJ Way. And that model is designed to provide midwifery care regardless of your plan of birth in terms of your place of birth. And her staff has demonstrated improved outcomes, even for families who are not actually having their baby with the midwives at the birth center. So, I mean, we know there's plenty of research and data that says that midwives, direct entry midwives, certified nurse midwives, that care provided by midwives improves outcomes. And so the fact that, unlike other places in the world, the majority of American women and birthing people don't have access to midwifery care in the same way is a problem. And, I don't think that we will see the kind of improvements that we need to see for families in outcomes around birth and pregnancy until midwives, the midwifery workforce is grown, and until midwives are are moved into that place that they are in countries like Japan, the United Kingdom, Sweden, where they are the primary care providers, that, in increasing access to midwifery care and building the midwife workforce is definitely something that should be lifted up as a way to address our outcomes that we're seeing.
I love the way you describe everything. I hear your activist side coming out. You're so passionate. You know so much. But how does it feel to go from practicing as a midwife at your own birthing center to being in Atlanta, functioning in a different capacity?
Well, I mean, the birth centers are different. So Magnolia is a much smaller facility, like literally by size, but also by volume. So, the Atlanta Birth Center is probably one of the busiest birth centers in the country, in the top, there are 400 birth centers, so probably in the top 10% in terms of the amount of clients that are seen and that are served. And it's 10,000 square feet almost. So it's a big facility. There are 3 birth rooms. There are 4 exam rooms. Its budget is bigger. It's serving, nearly 500 families a year, providing prenatal care and delivery at home, not at home, in the birth center and in a hospital. It has a much bigger staff, like several times the size of Magnolia. So I think that there's no way I would have time to be the executive director and also be providing patient care there's no way. It's just, there wouldn't be time to do that. But I think that my experience of doing both is useful because even though I'm not legally practicing in Georgia, I do understand, so I think that, if they were, they might have been able to hire someone who had the same amount of experience that I have in running a birth center, but that person may not have also had clinical experience, like providing the healthcare themselves. And so I think the fact that I understand and know intimately, like about what it's like to be the provider of the care, means that the decisions that I might make that are organizational are not distant from the care provision, right? So, like as an
I
administrator, I
love
might
that.
say something like, oh, we need to do more visits in a day, we don't have enough slots to see clients, and I might arbitrarily decide as an administrator, like instead of 45-minute slots, we're going to have 20-minute slots. But I know as a care provider what a difference that makes, right? So I might look for other ways to mitigate what it is that we're experiencing, that really prioritize both the provider's need to provide care appropriately and the client's need to have more engagement with their physician or their midwife. And so I think that that clinical provider lens does help to mitigate and inform and make more robust organizational decision making. And in many cases, I guess, like hospitals are run by people who were themselves nurses or who were on the floor. I think in those kinds of cases, you're getting a better quality approach to how decision making happens because it's not so distant from what it is that people actually need. And I think that also like resonates with even approaching midwifery as a calling or a profession from a lens that's informed by social justice or by history, right? So I'm not, or public health, I'm not just here providing healthcare one midwife to one client. I am providing care one midwife to one client in the context of a historical legacy and lineage of midwifery and midwives, providing care to from one midwife to one client across the whole community. I'm providing care within the context of a knowledge of public health that tells me that midwifery care is as an opportunity to solve some of the issues that we're seeing in terms of outcomes for families. I am providing care that attends to mental health and wellness because I'm also a licensed therapist,
I
and
was
so
going to
I'm
say
taking
that
into
actually. I was going to
yeah, I'm taking that
say.
into account. And so, I mean, I think what really distinguishes midwives is because, and it may be like, if you're a profession that has been like marginalized and like persecuted essentially historically over time, that's in the room, right? That's in the room with you. And so there is, I think, an inherent activism that is part of midwifery in general, in this country, but certainly definitely part of the legacy and the mandate of midwives who are, direct entry midwives, because, or who are community birth midwives, because that's our history, right? That's never not in the room with us, and so that historical context, we bring that to the families that we engage with, right? And that probably allows us to help them advocate for themselves and help them to empower themselves to get what they need, because that's part of how we have to operate as professionals, like as midwives. That's part of our own thing that we have to do. That's part of our own work that we have to do as midwives. And so it's really second nature to try to arm clients with those tools or facilitate their awareness of how they approach their care, needing to be informed by that.
I think it's amazing how you're able to look at midwifery in the context of history, both within the community and, now, of course, more recently, clinically in hospital settings. And then hearing your story, there's so much to celebrate in you, Tamara. If we go back to your intro, you as a psychology major, now a licensed therapist, you bring so many layers to your midwifery role. You bring the history, you bring psychology, you get into the psychosocial, back to your comment about the fabric and looking at the many layers that we are as humans. You have the ability to really apply a different lens in affecting community on a one-to-one level in the birthing context and setting, and then on a community level. It's really powerful. How are you liking the experience now in Atlanta, in a state that doesn't allow you to practice midwifery?
I think one of the things I've learned in the last couple of months is just that the same struggles, birth centers that are in urban areas that are serving majority low income families, majority Black families. Medicaid as a payer is a terrible business partner. And even in a birth center that is significantly larger than the one that I founded, the issues are similar. It's similarly hard to find staff for what a nonprofit birth center can afford to pay. It is similarly hard to deal with insurance companies and get your payments in a timely way. There's an insurance company currently that owes the birth center, six figures, that's been pending for several months. So a lot of the parallels I didn't expect with like a bigger staff, bigger budget, higher client load, that really most of the concerns and the pain points are the same. And so, for me, that underscores that there needs to be like action at a level above mine, in terms of like a systemic way of addressing, how we know that this model of care delivers better outcomes and experiences for families. We need to provide this model of care with better resources, right? So there needs to be, value-based payment models. Susie Q Birth Center has a 14% C-section rate, and, John Doe Doctor has a 45% C-section rate. You should incentivize me for the medical care that I'm providing, because I'm costing you less. Every client you send to me is so much less likely to have a surgical birth and all the costs and consequences to their health that might come out of that. And so I think value-based payment is a way to try to address some of the things that are happening with birth centers in terms of sustainability, but also pay parity. Like if I'm providing in that first 24 hours a similar level of service for a normal low risk person that a hospital would, then I shouldn't be paid any less, for my 1 day facility fee than a hospital is, who's providing care to a normal low risk family. And so, there are structural things that impede the success of birth centers. And I think that part of what I'm feeling a couple of months in is just a frustration about that similar struggle. But it's also clarifying, about like where it is that the work needs to happen. The part about not practicing, I really have not sort of dug my feet into the group of folks that are working on legislation in Georgia for direct entry midwives. But as someone who's running a birth center, I do want there to be more midwives and to have access to more midwives as an employer. So I think there are some opportunities for coalition building among organizations that serve families. That looks kind of like, maybe something like, we've heard a lot, or some of us have heard a lot about the momnibus bills that are in Congress that are attempting to address maternal mortality and maternal health care. And there are some states who are doing those kinds of bills at a state level. Colorado's one, Michigan is another. So I think, Georgia would benefit from a state specific, like mini momnibus bill that is able to pick up and capture some of the things that we and partners and stakeholders can come up with around what are some things that we can do to improve outcomes for families. Georgia's ranked in like the bottom 10 states for maternal mortality, infant mortality, and poor outcomes. So 40 something, I don't know, 49, 48, in that range. And so what are some things that we can do to improve outcomes, and how can the state bring resources to facilitate that? And I think legislation could be one way to do that. So I think much more policy and politics, but the politics of like state level politics is probably not something I was super involved with in Florida, but definitely I think because there are fewer birth centers, needing to really build coalitions and partnerships among with other organizations, and think about policy work as being part of something that the birth center has to do. And I think that's not an intuitive thing, but it is something that folks who are running birth centers in similar settings are increasingly becoming clear about. Like, policy work is part of what we have to do on a state and national level to get the resources we need for families.
That's the, I keep using the word interesting, but what I'm finding fascinating, it's as almost, Tamara, if I look at your journey, going through the midwifery, the one-on-one, the being part of the whole care for the woman and bringing babies into the world, and then going off and doing what you're doing. Even when I think about your introduction of your activism side, coming and now, starting a birthing center in Florida, and now running the Atlanta Birthing Center, which is a lot larger, you said, now to going into public, to thinking about policy. Like, it's almost like when you think of you went into this from a community perspective and really going back historically. And maybe the closed loop of it is the policy, because the policy brings it to the community. And so, and it seems just like I'm just in listening to you. I mean, first of all, I feel like I'm learning so much, but you seem like you have a tremendous voice in this space. And so are you seeing yourself like just bringing that up? I know that might not be something that you've done, but are you seeing policies as part of your near and long-term future as you think about your career in midwifery?
I don't think that I want to be like the equivalent of like a lobbyist, let's say, for birth centers or midwives. But I do think that there is policy work that birth centers and midwives who are caring for families at this scale, who are caring for families in this particular, highly urban areas, high density of like poverty and other social determinants in your client population. I think there's a particular lens that folks who are doing birth work in those communities have, that definitely needs to inform conversations about how we move forward to address maternal health care. And so I think that midwives need to be part of that conversation, birth centers need to be part of that conversation, doulas need to be part of that conversation, lactation folks, people who do like case management and care coordination for pregnancy, that like there is a cohort of individuals who are across different specialties who are caring for client populations during pregnancy that, fit that box, let's say, who do need to be part of the policy conversation. And so I think that we can create our own space to have that conversation with each other and then figure out how to get what we are learning and know up or across to wherever it needs to go. And in states that have a lot of work to do, I think that that becomes more important. There are states in the country that are doing better at this than others. California is a good example of a state that's doing some of the work that needs to be done. New York is an example of a state that's taking steps to do some of the work that needs to be done, although New York doesn't have a licensure law for midwives who are not nurses either. So, I mean, there's a lot of being part of this community of around birth of healthcare professionals around birth that feels like it hasn't changed in the last 20 years. The C-section rate is still high. There's still too many babies being born too early. There's still too many babies dying than should. And then there is part so that feels exhausting and like, what is the point? And then there is another part that there are things that are changing. And so we are, midwifery as a thing that is helpful feels more part of the normal lexicon of conversation around pregnancy. That wasn't true 20 years ago. Doulas as a necessary component of a care team, that feels more salient now than it did 20 years ago. Just before the pandemic, there's been a 300% growth in the number of birth centers between 2018 and now. Just the pandemic and all of the duress that we were all under during that phase of the pandemic has led to the racial reckoning of that time. All of these things that were happening. There are now, we went from say 15 birth centers that were run and operated by Black folks and other communities of color to like double that number and double that number in development, right? So the number of birth centers that will exist 5 years from now, serving communities in areas like Atlanta and Miami will be so much different. And those birth centers have the capacity to grow a workforce of midwives who are culturally matched to their community, have the capacity to deliver outcomes to communities in the way that they need to receive them, and to have, to be dynamic enough to have community driven and community led solution making for what works for them. And so that specifically, there's a whole organization, Birth Center Equity, that has made it its mission to raise $100 million for BIPOC-led birth centers. That didn't exist before the pandemic. There are birth centers whose doors remain open. Atlanta Birth Center is one of them. Magnolia Birth House is one of them, based on some of the financial support that was received. And so I think if people are looking to this cause of improving healthcare during pregnancy speaks to them, or specifically the idea that there are these health inequities that are faced by Black women, by Indigenous women, and they want to be part of that conversation and contribute to that meaningfully, resourcing birth centers, if you resource an individual midwife, then yes, that midwife over the course of her lifetime, she goes on to care for families. But when you resource a birth center, you're resourcing the whole community, right? So, someone who steps in and says, I see that, Atlanta Birth Center has a $500,000 gap in its budget that's caused by such a high level of care, has cost to deliver it, and Medicaid as a major payer for that care is causing a resource gap. I'm going to step in and close that gap for your birth center this year. Or, Magnolia has a, $200,000 gap. I'm going to step in and cover that gap. That totally transforms like how that birth center approaches, how it provides care in the next year. They're not scrambling for these, small dollar grants to keep their doors open. They are now looking out at their landscape with like this possibility of abundance. And I mean, I think the same, we should think of midwives as resourcing families in that way, right? Your midwife sits with you and is interested and invested in what it is that you're doing, how you're approaching your pregnancy, how parenthood is going to unfold for you. And that just opens a whole window of possibility for how you approach everything, right? Suddenly I know that I'm going to call someone and they really care about how I feel. So I'm more interested in little changes in my healthcare or how I'm feeling because someone's actually going to hear me when I tell them I have an issue. So I'm more attentive to myself. I am more invested in how I go about my day as a pregnant person because my care provider is invested in me. And so I think, we need for philanthropy and for, state legislation, for, funding and funders to really resource midwives and birth centers in the way that midwives and birth centers resource families. The way that we step in and care for families, this whole person, holistic wraparound approach. We need philanthropy and government to resource midwifery and to resource birth centers in that way. And I think that when that happens, we'll see outcomes transform necessarily because we already have the data that shows that they do.
I think it's interesting when you look at maternal health and you look at philanthropies like the Bill and Melinda Gates Foundation, who do so much for maternal health in developing countries. Yet it's interesting in the US, there's so many gaps that are ignored. To your point, if we resource midwives and birth centers the way midwife and birth centers resource the community, we'd close many gaps. And so I'm just thinking there's so much with that. I'm sitting here in pause, but I'm wondering, is there anything else you'd like to share about your life journey? I mean, we really didn't touch on your therapy experience. You have so much richness in your life.
I discovered, so like I mentioned, when I was a psych major, the pathway that I saw in front of me, and it might just be, the kind of academic institution I was at, that it only looked like I could go get a PhD in psychology, which actually has almost nothing to do with actually doing talk therapy with families. And so if I was interested in doing talk therapy, it was very unclear to me how I would get from point A to point B. And I didn't want to go get a PhD in psychology at the time. And like I said, that wasn't a pathway that seemed a linear pathway to doing talk therapy. And so when I was in midwifery school, actually, the person who ran my midwifery program was a midwife and a licensed mental health counselor. And how that came about was that there was a period of time in the 80s that the midwifery law closed. So the law was reopened. They did this whole big push to reopen the law. And then there was a confluence of circumstances that caused the law to close. And when the law closed, the midwives that had been practicing, they all went and got different careers. So one of them became an acupuncturist. One of them became a massage therapist. Well, my program director became a licensed mental health counselor. And so that generation of midwives who then got the law reopened in a couple of years, they all had other jobs, like other identities, other professional identities. And so she was is a licensed mental health counselor, and I didn't even know that was a thing. Thank you, Princeton. No, thank you. I didn't even know that was a thing that people could do. So when I fell down the rabbit hole of licensed mental health counselor, then I discovered clinical social work and I discovered marriage and family therapy. And I was like, oh, I can be any of these things and do talk therapy. And the more that I researched those three pathways to providing, one-to-one or a group, to providing actual therapy to families, I discovered that marriage and family therapy is to psychology as midwifery is to obstetrics. And so marriage and family therapy is a very whole person approach to therapy. It's a very systems-based approach. The problem is the problem. The person is not the problem. And so immediately, even though my mentor and my program director was not that kind of therapist, I discovered that was the kind of therapy that most aligned with how I saw the world and aligned with midwifery as a profession. And so I actually applied to be in a graduate program. There was one up the road from me at Nova Southeastern, and it was a postmodern family therapy program. And I started my master's program while I was still in school to become a midwife. So the last year of midwifery school, I was also in grad school to become a marriage and family therapist. And after I finished midwifery school, I spent several years working as a therapist primarily. So I finished my master's program. I started a PhD program. I did home-based therapy for families that were involved in the juvenile justice system in some way. So people who had other agencies and entities in their home, I did, home-based therapy for them. And so I took like a break from midwifery and involved myself in midwifery at a national level. I served on a couple of national boards, but I wasn't doing hands-on midwife work. And I think that how that informs how those years of working as a therapist in that way, and the years of then operating a birth center, and our birth center was preceded by like a parenting resource center that provided doulas and childbirth education and all of that, is just like what people bring into the room, what a pregnant person brings into the room as a client is so much, right? We don't know how much they're bringing into the room, but we have to wonder what it is. We have to be open to knowing that there's so much about their lives that we don't know. And so, when you're a therapist, that's the whole point, right? People are, you're getting under their hood, so to speak. Like, you are, in this case, I'm talking about the brain, you're getting inside there. They're telling you about their lives and their history and all of that. And so, I think therapists know that there's this rich backstory that are part of people's lives. And so, being a therapist means that when I'm talking to clients, the things that I'm curious about, when I'm talking to clients who are pregnant or interacting with families in general, whether I'm providing their medical care or not, that I am always thinking about all of the other parts of what's happening in their lives. And so I bring that into my communication with them, but it also applies to staff, right? So like if I'm a manager and administrator and my staff is having a problem, the problem is the problem, right? Not the person. The same thing that I would apply to them if they were a therapy client. And so it allows me to navigate, interactions with staff in a different way. It allows me to navigate being in places that are not staff. Like if I'm at a conference or I'm on a board, it just changes my ability to engage. And it's helpful. It's useful. It's useful in like mitigating conflicts and discord and, the work that we do as midwives, the work that's done in birth center settings, in community settings, at home births. It's such a challenging thing to be because we're sort of insider outsiders, right? We are part of the medical system, but only 2% of people, unless you live in Seattle, maybe it's like 4% there, but only like 2% of people in most places are having births in the community. And so we're part of the medical system, but we're also outside of it. And that creates a whole lot of like pressures and constraints that are really challenging. And so I think for me, being a therapist, navigating that space really helps me to make sense of what people bring to our interactions, whether those people are clients or those people are colleagues or those people are staff. And so it gives me the ability to give a lot more grace than I think I would if I wasn't a therapist. And to have a lot more like empathy, obviously, and compassion for folks, and to be able to get to whatever destination we're trying to get to in a way that doesn't, ask them to bring less of themselves, right? Even if you bring your whole self and some of yourself, needs some work or is challenged, is having a hard day, like I'm okay with meeting you where you are in that way. And I have more tools to do that than I would if I wasn't a therapist.
Wow, that's just, you are extraordinary. I have a last question, and then I'll tell you you're extraordinary again. My last question, I mean, I could talk to you forever. I mean, I'm like, I feel like you're a living, breathing book, but you're accessible. And so I love the combination. You just must be an awesome like midwife, just to be able to know people on so many different levels is just extraordinary. But my last question for you is, this is your platform to give a message to women of all ages, of all backgrounds, of all cultures. What do you want to say to them, Tamara?
So not all women have babies. I don't have kids myself. And so I think that for people who are either planning to or intend to have babies, or folks who have individuals in their lives who are going to be parents or who are going to be mothers, making sure that you are aware of all the different kinds of care that are available to you, and arming yourself with resources or tools to be able to make sure that the experience of pregnancy and birth is one that gives you something, right? It's not just take, right? It gives you something, that you leave that experience with something that you can hold in your hand. And that's not just your baby, right? So on some level, literally it is your baby, right? So you complete your pregnancy and your birth and you have a well baby and there is a well mom or a well parent. But also that's not all that you get, that you hopefully end that experience of pregnancy and birth feeling empowered, feeling energized, feeling in command of what's ahead, which is actually much harder, which is like the parenting of the actual child is like a whole, that's going to be happening. I'm sure my mom would say she's still parenting me. I'm in my mid 40s. So I think that we want families to to exit this point of pregnancy with a sense of being in command of the work that lies ahead. Well parents and well babies, that's all part of like the kind of society that we want to see and grow. And if we're bringing families into the world, families are coming into existence, like people partner, they have a baby, they become a family in a way that is frustrating, that is scary, that is inadequate, then that sets the foundation for the whole rest of it to be less than it should be, right? And so, there's this whole saying, like sort of hippie saying, like peace on earth begins with birth, and like it does, right? If we come into the world in a peaceful way, in a cared for way, and that can happen in a birth center, it can happen at home, it can happen in a hospital, right? But we just have to be more attentive to the opportunities that other types of care can provide. And so, midwifery as a model of care, a doctor can practice the midwifery model of care if the doctor is following those tenets, right? This whole person approach. And so, I would encourage folks to not, to put the same amount of attention they might put into like getting the best car seat so their baby's safe in their car, into choosing their care provider, into considering a doula, into taking evidence-based childbirth education classes, into considering a midwife, whether they're having a home birth or a birth center birth or they're birthing in a hospital, that you deserve to have a healthcare experience during pregnancy that leaves you as a vibrant, capable, well person. And that is possible. That pregnancy is not just something that you have to be afraid of, that it's not something that leaves you, it's not something you have to heal from, right? It should be something that you finish feeling like you can do anything, because you can, right? We know that women and gender expansive folks, we can do anything we put our minds to. And birth is one of those opportunities for you to learn that lesson really well. Like, I've got this, and you can learn that lesson, and you can have a home birth and a birth center birth or vaginal delivery. You could have a C-section in a hospital that you didn't plan to, and you can still exit that experience like, I've got this. I did that, right? I did everything I needed to do. I had all the information I needed to have. I had the care team I wanted. And so, we certainly don't want, morbidity and mortality to be the outcome, but we also want all the possible positive outcomes that are available to us. And that is possible, that is available. And I don't think a lot of women and birthing folks know that. And so, that's what I'd like to tell people, that you can have an amazing, empowering experience of pregnancy and birth, that is available to you, and you should seek it. You deserve it.
Thank you. That's beautiful and a great message to give women. Thank you for getting under the hood and sharing your life story and your incredible midwifery experience. It is eye-opening and inspiring, Tamara. Thank you so much. Thanks for listening to Under the Sisterhood. If you haven't already, please give us a quick rating and review on Apple or Spotify. And make sure to follow us on Instagram, Facebook, YouTube, and LinkedIn so you can hear from more amazing women. This podcast is created and hosted by Under the Sisterhood LLC and Elizabeth Elfenbein, produced by Elizabeth Elfenbein and Matt Butler, and edited by Matt Butler. The music is by Ayla Schaefer, her song Rose.